I'm here to bridge the gap between RCTs and real-world evidence and how much clinical relevance it actually has in the management of diabetes. These are my financial disclosures contracted by Novo Nordisk for this talk. Unfortunately, a lot of metabolic abnormalities are there in patients with diabetes, both type 1 and type 2, which drives a lot of macrovascular, microvascular, and also non-classical complications. Today, we also know that COVID can be a complication of hyperglycemia. So a lot of non-classical complications also driven by the metabolic abnormalities. And whatever said and done, we know a lot of talk about comorbidities. We should select drugs based on this, drugs based on ASCVD, CKD. Finally, HbA1c is extremely important. And insulin as a drug, which came almost a century back, is one of the top 5 medical discoveries in the world. It converted a type 1 diabetes mellitus, which was a fatal disease till then, into something which we are able to treat today. And today we know that type 1 diabetes has a lifespan almost equal to its age-matched counterparts without type 1 diabetes. And whatever said and done, insulin can give you infinite amount of HbA1c reduction, and premix is right there, up there as such. And whatever, today morning I had fafda jalebi, afternoon I had paratha and rice. We all eat this, whatever said and done. This is Shashank's starch study, which said whether you are in east, south, north, west, doesn't matter. 65 to 70% of our intakes come from carb. Whatever you do, it is carb. And we can't do without carbs. So there is a need to have Desi guidelines, Indianization of guidelines, and there's a huge need for us to not just copy guidelines, because in India also there's a lot of difference in ethnicity. I think East Indian is different from a South Indian, is different from a Kashmiri. So a lot of, I think not in my lifespan, but probably in the next 50 to 100 years, we will have ethnicity-based algorithms on management of all chronic care NCDs as such. So as you can see, despite similar fasting plasma reduction with basal insulin, very fewer Asian patients achieve an HbA1c goal, and this is from 16 randomized controlled trial. And we need to understand that post-prandial hyperglycemia is there, and post-prandial hyperglycemia has been linked to multiple things, right, for last 25 years, cardiovascular disease. But Monnier told us that the post-prandial hyperglycemia contributes only when the HbA1c is closer to goal, around 7%. And at the higher HbA1c, fasting is good enough. But data from Asia by Wang and all said that postprandial is important at every HbA1c. So whether you have HbA1c of 11 or HbA1c of 8.5, unless you have drugs which tackle postprandial hyperglycemia, you're not going to get patients to goal. So it's very important that we have solutions to our patients. And we just can't go according to the guidelines. And today we have, who had imagined that McDonald's would serve us at home, would get fries at home. So we have Indianization happening. And there's a need, and when I talk about this particular insulin, which is IDegaso, I say that this insulin is made for India. It is made for our Indian context, because it has all the makings of something which can tackle the Indian postprandial load. And what is important is that whether in the subcutaneous tissue, whether it is in the formulation, it maintains its distinct entity. So even when you have injected into the subcutaneous tissue, there's a sharp separation of curves of the shorter acting aspart from the longer acting degludex. And this has been seen with chromatographic studies also. And in the subcutaneous tissue, the phenol diffuses quickly, and the IDEG hexamers link up to form this long multi-hexamer, and this is the main site of protraction. And when you have the phenol which goes out, you have the biologically active monomers of IASP, and when the zinc goes out, you have the biologically active monomers of insulin degludex come into circulation. So it is, whenever I speak about this, I love my malt, and I say that it's like a malt with 2 cubes of ice, and the cubes never melt. they maintain that distinctness all through that malt. And we know that the postprandial hyperglycemia is linked to a lot of issues. It's linked to postprandial lipemia, and it causes a lot of oxidative stress. And days will come where, as we do fasting and PP, we'll have to do fasting lipids and postprandial lipids and treat postprandial lipids also. And there's a distinct prandial and basal glucose lowering effect of IDegaso at steady states. The pharmacological properties make IDegaso a prudent choice for once a day initiation and also for subsequent intensification. A lot of studies, phase 3A, phase 3B, or Onishi's data from Japan, Hardwood's data where they have compared IDegaso versus glargine, showing that it's better than glargine, not only in HbA1c reduction, but also in its potential of reduction in hypoglycemia. But we need to see whether this randomized controlled trial, do we have the same experience in real world evidence, So when I bought my, I drive a car which is very AI driven. So when I bought my car, I'm a rash driver. So my kids told me, Papa, you have to buy the safest car. Doesn't matter, And today, the safety of the molecule is extremely important, You may look here and there while driving, but if the AI notifies you there's something on the road or doesn't make you change gears, it is very, very important. And that's where we need to make sure you may have all these things which show that when, during a trial that, that a car bangs and everything, all the air, what are they called? Airbags come up. But in real world, if it doesn't happen, you die. So we need to see what happens in an RCT. Is it actually duplicated in a real world evidence also? So what are the key factors influencing clinical practice recommendations for choosing therapeutic decision making? One is the highest level of evidence always continues to be systematic reviews and meta-analysis. Then we have evidence from safety studies, evidence from large outcome studies, evidence from RCTs, evidence from personal and case reports, evidence from RWEs, and also clinical practice setting. Now, real-world evidence, what is real-world evidence? These are data which is collected outside the control restraints of a randomized controlled trial to evaluate what is happening in normal clinical practice. Now, when patient comes to us and we tell them insulin, the first thing is that, sir, इससे kidney खराब होता है. Sir, इससे वो होता है, ये lifelong लगने वाला है. Sir, you are punishing me because I am not done well. So there's a lot of myths and misconceptions. So what happens in an RCT and in a real world evidence is a huge amount of shared decision making which needs to be done. And there's an ever increasing role in decisions that affect patients' access to therapies. And RCTs tell us, can it work? Real world data tells us, does it work? So what are the RCTs versus RWE studies differences? RCs tend to be closely monitored and tightly controlled. It's like a classroom which has a teacher and a classroom without a teacher. You behave well when there's a teacher, and when there's no teacher, you don't behave well. So that's what happens in a real world, and we need to see that whether these drugs work similarly in real world evidence, and that's extremely important as such. So real world data can be generated from variety of sources: patient registries, EHR, administrative data, survey data, can provide different findings for a number of reasons: study setting, adherence to medication. If I think that 50% of our patients are adherent to medications and follow-up, our HbA1c would drop by 1.5%. There need not be any programs to do that. Placebo is not an option in real-world studies, so we don't know whether we are comparing to something. Again, population is very homogeneous versus heterogeneous, residual confounding to lack of randomization in real-world studies. Real-world studies implications is that the physician, there's a real-world picture of the disease, treatment practices, and outcomes. Regulators, long-term safety and pharmacovigilance. We know that there have been drugs which have been withdrawn because of real-world studies also. Even for patients, it improves the knowledge of the disease, impact of treatment of symptoms, and everyday lives of patients. So there have been a lot of real-world evidence with IDegaso. As you can see, a lot of our friends are also in there. And in the last 5 to 7 years, a lot of data has been generated from India as well. So does any real-world study of IDegaso help bridge the data gap in answering a very clinical question? Now, it's important that today we have the ADASD tells us start with basal insulin. That was based on the 4T study done a decade back, where you didn't have this kind of fantastic basal insulins. We have the IDF and the RSSDI say that you can start with premix or co-formulations. And the end of the day, everyone is confused. What should I follow? The ADA, ESD, IDF, or RSSDI? But I think the real world evidence tells us that what is actually happening in real world. And this is data which got presented at the IDF Busan in 2019 with Dr. S.R. Chowdhury. And what they looked at is close to around 150 patients, with around 89 of them on IDegaso and 45 of them on glargine U100 and another 45 of them on glargine U300. And this is the retrospective data, but at least it tells us that what is actually happening in real world. And what you can see is that IDegaso caused statistically significant greater reduction in HbA1c as compared to U100 glargine and U300 glargine. Nothing about rocket science there. You know, you have a shorter acting insulin, you will have a better HbA1c reduction. But what is important is that you had significantly better fasting plasma glucose reduction with IDegaso compared to U100 and to U300 glargine. And in IDegaso, you are only 70% as basal insulin. That is something you need to take care of. And the interpandal control becomes better when you have a flat peakless insulin. And our televisions have become flat, but our insulins are also getting flatter. Again, there's a significantly better PPG reduction with IDegaso compared to U100 and U300 glargine. If you can look at a significant increase in insulin dose requirement in insulin glargine U100 and a non-significant increase in U300 glargine. And again, most importantly, when we compare to insulin, whether it's a head-to-head glycemic equipoise study, you may reach similar HbA1c. But the difference between two insulin is based on multiple other surrogate markers. Markers could be total dose of insulin, weight gain, and hypoglycemia. And hypoglycemia continues to be one of the topmost surrogate marker in distinguishing two insulins, because you may reach an HbA1c if you uptitrate the dose. Here you see that there's no difference. In a real world data, there's no difference in hypoglycemia between IDegaso, U100 glargine, U300 glargine. Then why should we be using basal insulin to initiate? So Indian realities of diabetes management requires total control at initiation of insulin therapy. IDegaso is a simple, convenient solution with proven safety and efficacy as shown through multiple RCTs. Findings of multiple RWE studies with IDegaso corroborates with that of RCTs. RWE with IDegaso has also shown significantly better control for HbA1c and PPG as compared to U100 and U300 glargine with similar safety. Thank you all for a patient hearing, and we'll take up questions at the end of the session. Thank you.